Good afternoon for all of you. I'm so glad to be here, and thank you, Sajid, for the invitation. This is my disclosure. The open abdomen is a part of a temporary abdominal closure for multiple abdominal disease like peritonitis, trauma, and damage control. Nowadays, negative pressure wound therapy has become the standard of treatment in patients with open abdomen because he has shown multiple benefits like sepsis control, reduce the surgical intervention, adequate tissue healing, wound care, and an important point in these patients is that decrease the mortality less by 13.9%. Most of these patients of open abdomen are in critical clinical state because these patients had emergency laparotomy. There are a critical nutritional status, old age, and critical illness. So we need to use the negative pressure wound therapy, but in the same time, we need to perform an intestinal anastomosis. So the question is intestinal anastomosis and this therapy, is it possible and safe for our patients? In our institution, in Military Hospital in Bogota, Colombia, we use the negative pressure wound therapy that is composed for these elements. The aptera, that is a non-visceral polyurethane fenestrate sheet that separates the gut to the abdominal wall, and it is connected a precut sponge, and there is a sensor tract that is on the precut sponge and is connected to the unit back ulta. All the patients keep the back therapy in a continuous mode and a ranging of pressure of 75 to 125 millimeters of mercury. All the patients, we calculate the Mahane index peritonitis in 3 groups. That is a prognostic tool on mortality. All the patients with morbidity using the Clavendin International Validate tool, and in 1 to 5, we follow up the patients and we observe the mortality. These are prospective study collected databases. All the patients who require the use of negative pressure wound therapy between 2014 to 2018, we were include 97 patients, and for this, 45 have anastomosis, and they use in the same time of negative pressure wound therapy, and with stratified in 2 groups, with and without anastomotic dehiscence. Our primary outcome identifies associated factors for anastomotic dehiscence in patients with open abdomen and the use of negative pressure wound therapy. There are the demographic, the baseline characteristic, age, gender, medical history, etiology, perioperative characteristic, PCR albumina, intestinal anastomosis, who we made the intestinal anastomosis, mechanic suture or manual, a number of anastomosis, and where is located, the anatomic site. The large fascial closure that is defining in our study that the close primary of the fascia after 30 days of the first surgery, patients who ended with a stoma, the classification MPI and Clavendin, days of back use, pressure of the back, postoperative fistula formation, and the follow-up of the patient's days and mortality. We calculate bivariate analysis and multivariate analysis with a significant odds ratio and the risk factor for anastomotically in this type of patients. Female population, history of coronary artery disease, the large fascial closure, and the back pressure. That is a significant p-value that with a difference between 2 groups. The groups with dehiscence have a higher pressure in the back with a difference with 10 millimeters of mercury versus the other group. And there are the risks of mortality in these patients, female population, MPI2, and anastomotic dehiscence. This patient, we follow almost 2 years, and there is a graph with a cumulative overall survival and a difference of mortality in these patients, with a difference of decrease in mortality in the group of no dehiscence for this type of patients. In conclusion, we have to take in account this risk factor: female patients, previous history of arterial coronary disease, MPI higher than 2, delayed facial closure, requirement of vasopressor to make into account to make better interpretatory decision. In the other hand, higher pressure used in the negative pressure wound therapy higher than 110 millimeters of mercury should consider the risk for anastomotic dehiscence, and we recommend lead pressure. And to answer the question, we can use the back therapy in this patient with low pressures. And dehiscence is an outcome, an undesired outcome for any surgery in the world that leads in multi-organ dysfunction, malnutrition, higher costs, and it directly associated to patient mortality. So we have to consider this risk factor in patients with open abdomen. Thank you.